Okay, welcome. Hi. Thank you so much for joining us today. We're really thrilled with the response. There's a lot of you out there, and we're really excited about that. My name is Sherry Hughes. I am one of the practice advisors here at the College of Physiotherapists, and I will be acting as the moderator today. With me are some experts from public health. We've got Madeline Ashcroft, Louise Azara, Isabel Guerrero, and a very courageous physiotherapist, Carolyn Van Dyken, who's going to share her story about an audit that she went through with public health. We have a ton of info to share with you, and we plan to leave lots of time for questions. Thank you very much to all of you who submitted questions in advance. We have all of them on a slide, and we're going to get through as many as we possibly can. You can also use the chat function to submit questions, but we will focus on the questions that were submitted in advance. And this session, the recording will be available on the college website afterwards, and any unanswered questions, we will make sure that we post answers to those as well. So let's get started. I'm just going to chat really briefly about the college standard first and what the expectations of physiotherapists are. And really, it's, the overall message is to identify and minimize any risks caused by infections or the use of equipment. And physiotherapists are going to want to consider the risks of transmission between patients and staff, with other healthcare providers, with equipment, all the various modes of transmission. Have a think about what those are and then put a plan in place. And really, we expect you to go to the experts for infection prevention and control measures. Stay current with what reasonable and usual practices are, and then incorporate them into your practice. They would include things like hand hygiene, the use of personal protective equipment, maintaining sharps and wastes, cleaning, disinfecting, maintaining equipment, handling soiled linen, those kinds of things. Have a written protocol that's available, and make sure that staff are aware of what needs to be done and that you update those periodically. And then the other thing that we have listed on the standard on the college website is a link to a bunch of resources. And fortunately, again, we're fortunate to have many of those experts here in the room who are going to share lots and lots of information with you. And so at this point, I'm going to turn it over to Carolyn Van Dyken, who is a physiotherapist, and she is going to tell you a little bit about her story.
Thank you, Sherry. Thank you for the introduction, and thank you for the opportunity to take a few minutes to speak. The idea really today, from my perspective, is just to kind of give you an idea of what I went through last March, having received a phone call from public health that I had received a public health complaint. So I've been in practice for 32 years. I have been practicing orthopedics and pelvic health physiotherapy and pelvic health almost exclusively for the last 20 years. I own a teaching company, Public Health Solutions with Nellie Fagani, and so we teach a lot of physiotherapists around pelvic health, and a part of that, of course, is standards for infection control and safe management of bodily fluids, which of course in pelvic health is a relevant concern. So I had actually received an email saying that public health had just been into my office. At that point, I was renting space from a yoga studio, so I was renting 2 rooms, and they had just come in to perform an audit because they had received a complaint from one of my patients. And so, as I'm sure all of you can imagine, that was a pretty scary email to receive. It's not something that any of us is prepared for. I'd been practicing for a long time, and I had prided myself on having good, infection control standards and cleanliness standards and personal sort of practice around that piece. And a public health complaint is always an anonymous complaint, and it was pretty apparent to me. So it was a Friday actually that I got the complaint, and because I don't work in the office on Fridays, it was Monday that they were coming back. And so I had a pretty good idea actually of who the complainant was, because we had received an email 2 days prior to that from a patient who had just received a stim unit to practice some electrical stim at home with her pelvic floor. And she had called into the PT assistant and had said that she didn't think her gel bottle was sterile. And so the PT assistant actually sent the email to me. I had responded an email to her and actually phoned her as well in response, and I had not actually heard anything. So the next thing that I had actually heard was from public health. So on the weekend, of course, I went through all of our infection control standards and went back to the website and tried to sort of look at, our policies and procedures and what we were doing to make sure that we were in alignment. The actual audit actually was a great experience, and that really what led me to saying to the college, we need to actually probably do a webinar to sort of bring this scope of practice or bring this sort of standard out into the open a little bit more. There are many things to consider from an infection control perspective, and certainly in pelvic health, that's true. It's interesting, as educators and instructors over the last 2 months prior to this complaint, we were just wrestling with the fact that there was a 2015 Health Canada standard which said that we must use individualized packaged lubricants with our patients when doing an internal exam on mucosal tissues. And that had not been sort of the standard of practice that had been taught up to that point. I had actually always used individualized packages because I was just more comfortable with that, but it certainly wasn't something that was being consistently taught. And so as instructors, we were starting to say, okay, this is the standard, we need to make this change. And all of that happened at the same time as I got this complaint. So the complaint really, from my perspective, was about electrical stimulation, a gel bottle that I had given to the patient to use with her e-stim at home. Of course, with electrical stim in the pelvic floor, patients purchase their own probe, so they're single use. And so that was not the problem. I knew for sure that, that was not part of the complaint. And I was unsure kind of, I had not refilled the gel bottle. The issue was that I had actually opened the gel bottle previously in the clinic and had used it with another patient, the gel bottle on a probe, and had sent actually that gel bottle home with the patient. But the patient had actually never used it because the next day after she was home from my office to start STIM, she actually was diagnosed with breast cancer. So she was a 75-year-old woman, and she actually, returned the unit, which we lend out at that point and have a policy and procedure for cleaning the unit when it comes back. But the gel bottle had not been used. So I had used that gel bottle again for my next patient. And because it had not been sealed, the patient felt that it was not a clean, sort of sterile unit. Of course, with gel, we know it doesn't have to be sterile, but it does have to be single use or single patient use. And so that really kind of led me down this journey, looking very carefully at our policies and procedures, looking very carefully at the college's standards. And one of the big problems for I think us as physiotherapists is that a lot of the links that are on the college's website are to sort of medical clinics and for physicians' offices. And so it's harder to kind of figure out, well, what applies to us. And so it's been really great from public health perspective for them to kind of come along, and they reviewed all of our policies and procedures and gave us some great recommendations. And that's really where this has come from. So I'm going to turn it back over to the experts at this point and would really encourage that, many of us know much of what we need to do, but I think there's a lot of sort of more fine details that we need to certainly be more aware of. So that's what today is about.
Hi, so my name is Louisa Zara, and I'm a public health inspector with the Simcoe Muskoka District Health Unit, and I met Carolyn as one of the investigators. And I just want to talk about what the public health unit does and how we support our healthcare facilities. Next slide. So the role of the Board of Health, I'm from the health unit, the Simcoe Muskoka District Health Unit. We investigate complaints. So if a complainant phones and says that they've seen an IPAC breach or they've seen a lapse in IPAC standards or best practices, they will phone us up, and we are required under the Ministry of Health that we respond within 24 hours. We're also, when we are investigating reportable diseases, We can, when we discuss with our clients how they might have acquired their reportable disease, then we might do an investigation with a healthcare practitioner if there was a procedure done that might have caused that reportable disease. And what we do is we always call the regulatory college to see if they can come with us to do the investigation as well, because they have a lot of knowledge of what their healthcare practitioners do. And usually, because it's very difficult to have somebody come in from the college, then we will, as the health unit, go and investigate on our own. We also we don't routinely inspect healthcare facilities, and so there's a new protocol that allows us to respond to complaints. And so then we can go into a facility that the regulated health professional operates, unlicensed daycares, community centers, rec centers, schools, and other facilities. Because as a health unit, we are regulated to go into food establishments. We are regulated to go into personal service settings. We're regulated to inspect public schools. But again, now we have a role where we are investigating complaints. We are to provide guidance for IPAC improvements, but we also can order, make an order under the Health Protection and Promotion Act. And we also have to publicly report any disclosures. So again, if we see that there's an IPAC lapse, we do have to report to the public. It's part of our transparency to the overall public, so they know that if there's a facility that has an IPAC breach, that it is placed on our website. And this is because there is an infection prevention control complaint protocol that requires us to do so. Next slide. Again, we talk about the Section 13 order. We really don't use it if we don't have to, but it is a part of the Health Protection and Promotion Act. And if there is any kind of an existence of a health hazard, then we can do a Section 13 order. The Section 13 order outlines the direction that the health unit can use. So say if there is a service that we see that there's an infection control health hazard that could spread infections to other clients, we can ask that the order can be put in place to stop that service from happening. If there's like an autoclave that's very old and it's not used properly, we can ask that the autoclave not be put into use. We can ask for things like lists of your clients' names if we need to contact them to tell them that there is a breach. And then two, before a service is allowed to go back into place, then we must do a reinspection. Next slide. So what is an IPAC lapse? So it's a deviation from IPAC standards of care, and it's all based on current IPAC best practice documents where it's available. And again, if the medical officer of health, he's in charge of the health unit, and myself as a designate, if we believe on reasonable probable grounds that there is this deviation, and this deviation in your IPAC practices results in an infectious disease transmission to your clients or to a staff member through exposure to blood and body fluids and or potential infectious lesions, then that is considered an IPAC lapse. Next slide. And so how we do our investigations, again, we get the complaint and it's received and we review it and determine if there's a risk to the public. And again, we only have 24 hours to respond to an IPAC complaint. So if it's made, we do have to go into visit the facility where the IPAC complaint is within 24 hours. The investigation is conducted on site to validate the complaint. Again, we get many different complaints. We really do want to go in and visit and validate it to make sure that the complaint is valid. We use a risk assessment. We use our Public Health Ontario IPAC audit tools, which Public Health Ontario will talk about. We use best practice documents or CSA documents, Ministry of Labour documents. And we also look at your own IPAC standards of care. So as a college, if you have IPAC standards, we actually pull those up as well to make sure that you're following them. And then too, it helps us to see what you're doing. So a practice deviates from IPAC standards, and that's where we see any type of disease transmission. That is when we publicly disclose on the website. So when we were working with Carolyn, there was things that she was doing that she needed to improve upon, but there wasn't anything that we saw that there was any disease transmission, and so we did not post. She wasn't publicly disclosed. We just worked with her and helped her to follow best practices. But again, there wasn't any links or any disease transmission, and so we did not publicly disclose. But we have publicly disclosed other facilities and healthcare facilities as well and professionals who deviate, and we have seen or could potentially be disease transmission in their activities or the procedures. And then if there's any evidence of the elevated risk to the public concerning any transmission of bloodborne infections, HIV, hepatitis B, and hepatitis C, then we start initiating public notification. That means we need to tell the public that they've been exposed to a bloodborne infection. And again, even if there's a low risk to that procedure, and if somebody can acquire an infection, we do publicly notify the public because it is our responsibility to do so. Next slide. So things that we're looking at. So again, we came in and visited Carolyn, and these are things that we look at when we're doing an IPAC investigation. So again, your policies and procedures. It's the first thing we kind of look at. Do you have your policies and procedures in place? Because that helps us to, to assess if you are following things. Are you cleaning things? Do you have policies and procedures on hand washing? Do you have policies and procedures for occupational health and safety? Is if there's a bloodborne exposure to one of your staff members or to yourself, is there a policy that tells you what you need to do if there's been a bloodborne exposure? Or is there a policy on how you're cleaning? Is there a cleaning schedule set up? So that's what we look at when we're looking at your policy and procedures. And next thing we look at is your hand hygiene. Do you have hand hygiene facilities? Is there a sink to wash your hands? Is there soap? Is there water? Is there paper towels? And it has to be a point of care. So wherever you're doing your procedures, you need something somewhere or some place to do your hand hygiene, and it needs to be done at point of care. And if you don't have a sink, well then we'll use ABHR. If you have ABHR, that's 79%, and we're looking at all those things. And do you have a policy on hand hygiene? And do you have a procedure on how to do hand hygiene within your practice? Other things we look at is clean and disinfect your shared devices. So again, you need to look at your manufacturer's instructions for use for all the devices that you have within your facility. And that's what we asked Carolyn. So do you have the instructions on how the device needs to be cleaned? And the manufacturer's instructions, they will tell you. Again, I work for the health unit. We're starting a new vision screening program for kids. And we have lots of new equipment that's going to come into the health unit. And my job is I phone up the manufacturer and say, how does this device get cleaned? What kind of disinfectant can I use on it? When does it need to be cleaned? How many times can I clean it before it deteriorates? And then again, I have all those procedures to provide to the staff. And so when you are purchasing a device, make sure you know how to clean it and disinfect it. And if it's a shared device, if it needs high-level disinfection or it has to be sterilized, again, you contact your manufacturers that creates the device and ask them. Next slide. So reprocessing medical devices, if you are reprocessing, that means you're wanting to make sure that you're using multiple devices that are used multiple times, and you want to make sure that they're clean and disinfected or sterilized properly. And so we're looking at all the policies and procedures on how you are sterilizing these devices, if you're using the proper autoclave, if you're following the manufacturer's instructions for use for that autoclave, if you're using high-level disinfection. Again, we're looking at your schedules, we're looking at how you're testing the high-level disinfectant, if it's used, if it's expired. Again, we look at all the different processes and we help you as well. So if we're there and you have questions about the device, well, then we provide you with some answers and help you with the investigation as well. If you have environmental surfaces, cleaning and disinfecting, how are you cleaning it? Do you have a schedule that's set up to show us how you're cleaning, what you're using, the manufacturer's instructions again, if you have a bed, if you're allowed to use disinfectants on it, again, in your cleaning and disinfecting, and when you're cleaning and disinfecting after each patient care, we're looking at that. And then things like your single-use disposable items. So this is one of the catheters that when Carolyn was using, we have to make sure that these devices, one, if it's a medical device, it has to be approved in Canada to be used. And that was one thing we did with Carolyn is we went and investigated to make sure the device actually was approved to be used in Canada, and this one in particular was not. And two, because it's single-use disposable, it has the number 2 with the slash on it, which means it cannot be used again. So that means it can't be cleaned and disinfected, nor can it be used on a single patient only more than once, because the manufacturer cannot. Again, they only test it for one use. And so if it's used multiple times, it's not just an infection control issue, but it can also be a danger to the client to use a device more than once because it's not been tested for that purpose. So again, always use your manufacturer's instructions for use and make sure that all your devices are approved to be used in Canada. Next slide. We're looking at your waiting area and screening of clients. So this is just your passive screening. So people, your clients are coming in, you don't know where they're relatively healthy because you are providing physio, but you don't know if they have a cold, influenza. They could have an infection that they could be carrying as well. But you do screening so that you're protecting yourself and you're protecting your staff. Again, you are not healthcare providers providing, how can I say it? You're not treating them for infectious diseases, but you're treating them to do physio with them. So you're not wanting a client to come in with an infectious disease that's going to infect your staff. And so the screening is done prior to make sure that a client isn't infectious when they're coming in and you're having services provided on them. Two, you want to make sure that you have hand hygiene facilities for them so that they can clean their hands when they come in. There's cough etiquette, and making sure that there's masks. If they do have a cold and you decide that you're going to provide treatment to them, that they have a mask on. Then there's sharps disposal. So we're making sure that all our sharps are disposed at point of care. I've gone into actually one of the colleges that provides education to physios and things like that. And we always talk about where's the sharps going, where the sharps container needs to be. And it needs to be at point of care. And we have to make sure that it's very close to where the procedure is being done. Because you don't want to be walking around with sharps and cause an injury. And so we make sure that our sharps containers are also locked up and that they are at point of care. And then we're looking at personal protective equipment. Do you have it for anything where there's blood or body substance exposures, or if you're going to come in contact with your client and there's blood and body substances, you're doing your risk assessment, and we need to know that you have your personal protective equipment there, that your staff are trained on it as well. And so, again, that was one of our investigations. Thank you.
Thanks, Louise. And I'm Isabel from Public Health Ontario. And just before I get started, just quickly, just for clarity, so there's public health units that go in and do these investigations. And then there's Public Health Ontario, who then supports the public health unit. So Public Health Ontario doesn't go in to do any of the lapse investigation. We simply support either the health units or now the regulatory colleges. So we have had some that have come forward to ask us for support during some of their inspections or investigations. Next slide. So Public Health Ontario, PHO, just want to describe a little bit of who we are and what we actually do. So ultimately, we are a Crown corporation, and we are dedicated to protecting and promoting the health of all Ontarians. And we definitely look to reduce the inequities in health. We do our best to link public health practitioners, frontline health workers, such as you, and researchers to the best scientific intelligence and knowledge. And we provide expert scientific and technical infection prevention and control advice and support as well. And most of our clientele are basically from local public health units, regulatory colleges, government agencies, and healthcare providers and institutions. Next slide. So how do we go about working with the public health units or the regulatory colleges? So what we do is we respond to IPAC inquiries. If they have any questions, if they have any issues that are related to infection prevention and control, we do our best to provide some guidance and support. We develop IPAC, or infection prevention and control resources as well. So we do have the IPAC checklist or audit tools, and we do offer training specific to infection prevention and control. We also collaborate on education sessions. So if it's much like this one, so we do like to collaborate with other partners to provide education. We collaborate on infection prevention and control communities of practice where we have an opportunity to discuss specific IPAC issues in a group setting. we review practice standards as well. So we have done some reviews of practice standards, CNO and RCDSO and so on. And we support IPAC lapse investigations with risk assessment support. Next slide. So during an IPAC lapse risk assessment support, and again, the health units, they investigate lapses day in, day out. So we are not asked to provide support with a risk assessment all the time. We would only provide support if there's a sense that there is, or there's a strong chance there's going to be transmission or has been transmission of an infection in some form or fashion. So they just want us to do a risk assessment to find out what the risks are to patients or clients who were exposed. The response and system support, we assess the risk of transmission of infections. So we do look at what is the risk of bacterial transmission or viral transmission. So that is basically what we look at. The response and system support team, which I'm a member of, we respond to requests for a risk assessment, and that then supports the decision of the medical officer of health. So one of our program IPAC specialists leads the risk assessment support. And what we do is we bring back the information to a core group within Public Health Ontario that may include the IPAC manager, the director, or the chief. And we may include an additional physician, depends on whether or not we feel that it is needed. And then we would also involve the laboratory or epidemiology support if we feel that there is a potential for notification of patients and clients. Then we would definitely make sure that they are aware of the situation. Next slide. So to continue, we base our recommendations on information provided to us by the public health unit or the regulatory college. So any decision we make is based on what they've actually given us or what's been brought to our attention. We oftentimes look at the information and feel that we need more. So we just go back and forth with the public health unit or the regulatory college, asking a lot of questions and then getting a lot of our answers. And we provide the recommendations in a summary report. And within that report, we advise as to whether or not there was a risk of transmission of infectious disease. And then we also offer advice on patient notification as needed. But again, the final decision related to notification is entirely based on the medical officer of health or the associate medical officer of health. So they have the final piece. Next slide. And this is sort of the anatomy of an IPAC lapse investigation. So Louise spoke to the complaints coming in. So you can see this on the screen. It comes in, they address it. Sometimes they'll bring in the ministry. Sometimes they won't. It all depends on the situation. And then, of course, the regulatory college, most appropriate regulatory college will then be notified in many cases. And then there's Public Health Ontario, where we do provide support, as I mentioned, with the risk assessment or answering any questions that they may have related to infection prevention and control. And then there is a list of tools and resources that can be accessed and shared with them as well. So I'm going to turn it over to Madeline to continue speaking about tools and resources.
Hello, thank you. Thanks, Isabel. And thank you, everyone, for your interest in today's session. So I'm Madeline Ashcroft, and I'm one of the IPAC specialists at Public Health Ontario, and I'm on the other team, the regional support team. So I would like to share with you some of the resources we have at Public Health Ontario that will help you in your practice. So my objective is to be able to, and you will be able to at the end of this, outline the supports and resources from the point of view of teams and people, and also online materials. Next, please. So when you have any lapses or when you have inquiries, we have our two particular teams in our IPAC department. We have more teams, but response and system support is the one with Isabel. And this team deals with province-wide issues, lapses across all settings, professional colleges, and government. The regional support teams support organizations to interpret and adopt best practice. So we respond to inquiries directly from frontline people or anybody else, organizations as well. And we work with you to have collaborative education and dissemination of any new resources that come along. And we facilitate sharing of challenges and opportunities and successes in communities of practices, bringing like-minded people together to share, working groups and networks. Next, please. I meant to say with that one also that we are aligned with health unit boundaries now. We used to be regional infection control networks, but we got realigned about 2 years ago with health unit boundaries. So Central region is the one that I'm working in right now, and we cover from up in Simcoe, Muskoka, east to Peterborough, west to Peel, and all health units in between, including Toronto, Durham, York, etc. And you can locate your local office, one of the 5 offices across the province, on our website, and I'll tell you how to get to that in a minute. But there's an office in Ottawa, one in Toronto, one in Cambridge, one in St. Mary's, and soon to be in London once the new lab is opened there, and one in Sudbury. Okay, so somehow I've missed where to find our IPAC resources. Are you able to go back one slide and see if I've chopped that one out? There we are. Yeah. So this is a key slide, but what I would say to you, rather than try to learn any links or anything, just Google PHO IPAC or IPAC PHO. If you just put PHO, you'll get Vietnamese noodles, but if you put IPAC with it, you will be taken to this page. And it's basically our infection prevention and control landing page, and everything you need to know or link to can be found on that page in some way, shape, or form. So instead of searching for bizarre things, just Google that. Also at the top of the page, you can click and search by topic in that top ribbon. Or you can also select infection control, prevention and control, as well if you browse by topic. So there's individual things, however you like to search for things. But I just do IPAC a PHO when I'm trying to find responses to people. Next, please. So you will find there we have online learning modules. That's also on that page, but it's also under online learning in the top right-hand corner of the blue bar at the top. And we have 2 IPAC learning modules, sets of modules that we think are very useful. So core competencies is the base IPAC information that all healthcare workers in hospital, long-term care, community settings should know. So we recommend that people look at these, maybe do them again on an annual basis, but it's basic knowledge. If you're the infection prevention control lead for your organization, you ought to know more than this, but everyone should know what's contained in these modules. And you can enter these and work through by setting as well as by level of care provider. And you log in, create a password, and then you can go in and out, and you can generate a certificate at the end to show your employer or for your own records that you have completed the modules. The modules, core competencies are interactive, and there's 6 modules. The first 5 focus on routine practices, and the last one on additional precautions. And the additional precautions is relatively new, but the core best practices: occupational health and safety, keeping yourself safe, And that includes personal protective equipment, the chain of transmission, and making a risk assessment. So how do germs get from one person to another, and how do you protect yourself when you are providing care? What's the risk to you in that setting? And that helps to inform your personal protective equipment. Healthcare provider controls, control of the environment, that includes cleaning and so on, the environment, and administrative controls, so that's more policies and procedures and so on that support a healthy workplace. And finally, the additional precautions are for when you have something that you know or suspect might be infectious, potentially in one of your patients or clients, and you might need to have protect yourself further with additional considerations for contact, droplet, or airborne transmission. So this is a baseline. We recommend everyone does it for your bottom line for infection control. The reprocessing modules as well in community healthcare settings cover cleaning, disinfection, and sterilization of medical equipment and instruments. Somehow I got muted myself, so I hope you heard that. So have a look at that and see if that would be applicable. The key principles apply to any setting. So one of the key things, of course, is you can't really disinfect or sterilize anything if you haven't properly cleaned it first, removing all soiling or proteinous material. Next, please. So our PIDAC, yes, we'll just click along here. So routine practice and additional precautions, hand hygiene, environmental cleaning, and cleaning, disinfection, sterilization. These are some of our core PIDAC, or the Provincial Infectious Disease Advisory Committee, best practice documents that would be useful in your setting. And PIDAC came to be after SARS, and they provide scientific recommendations and information to guide your practice in all settings. And so most of the documents do actually say in all settings. So they provide best practices, tools, and resources for cleaning and disinfection, sterilization. Routine practice and additional precautions is actually the base document of the core competency modules we talked about, as is hand hygiene. And the resources for routine practice and additional precautions have lots of information as well about antimicrobial resistant organisms like MRSA, VRE, CPE in Annex A. They have acute respiratory organisms in Annex B, B for breathing, we say, A for AROs, and C is Clostridium difficile. So if you want to find out something specific about any of those, it's all there. IPAC in Clinical Office document brings together a number of the best practices that apply directly to an office setting for a physician or another regulated healthcare provider. And it's probably the most relevant document for those of you who work in a community setting. It references the other larger documents, but it really gets down to some more key materials, and there's checklists and so on that make things easy to use in your setting. Next, please. So key messages overall is that hand hygiene is the single most important thing you can do to prevent the transmission of infection. Routine practices will protect yourself, your clients, and the larger society from transmission of infection. We say that in a perfect world where everyone did routine practices properly, you would not need to do any additional precautions except maybe for something that's airborne, but we know it's not a perfect world. So we do have those additional precautions. Physiotherapy settings require environmental surfaces and equipment to be cleaned and disinfected between uses at minimum. Products that you use for this need to have a drug identification number from Health Canada, so you've got to look for DIN. And used according to manufacturer's recommendations. So if there's any dilution, you have to dilute it appropriately. If there's a temperature requirement too, consider water hardness. That might be in the manufacturer's recommendations. And contact time is really important. So how long that particular disinfectant must be on a surface in order to actually kill the germs, and use it according to their safety data sheet. I've had a few questions recently about the use of essential oils in physiotherapy settings and places where this is a healthcare setting, and it's got people coming in as clients. It's not a home setting. Essential oils are fine in the home setting, but should not be used for cleaning or disinfection of equipment in your professional setting. They're not, there's not sufficient evidence to support their use, and they don't have DIN numbers for this. Next, please. So here's a few other relevant resources, and we will obviously share these links with you, but there is a risk algorithm for PPE use, which makes things quite straightforward. The environmental cleaning toolkit is really useful if you want to look at actual little videos of how things should be cleaned and so on. The signage, and something that Louise was referring to earlier, in clinical office settings document and in those tools, there's signage that you can use in your office settings. Please don't enter if you have germs. If you do have respiratory symptoms, etc., put a mask on, clean your hands, etc., and let us know, that kind of thing. Resources for preventing IPAC lapses, and some frequently asked questions. And the checklists that were mentioned earlier, there's one core IPAC practice in clinical offices, and there's another for reprocessing of medical equipment in clinical office settings as well. We also have antimicrobial stewardship resources, and although you don't prescribe, you may well be asked by patients and clients about antibiotic use for viral infections, or perhaps you want to know more yourself. So our online resources support prudent and appropriate use of antibiotics, which in turn, of course, helps to reduce the development of resistant organisms. Next slide, please. So that's the end of our formal discussion, and we hope that that's given you a little bit of basis of where to go and look, and we want to give you the proviso that we're going to focus on some basic principles in responding to your questions. We received about 50 before today, and so we've brought some together that were similar, and we got it down to 39. So we're going to do our best to take turns answering these, whoever is the most appropriate person perhaps to respond. And we just want you to know that we obviously can't provide in-depth responses, but we hope that we will address your concerns here. So I'm going to hand this one over to Isabel.
How about I get myself off mute? So I wanted to know if the information shared in this webinar also applies to other healthcare providers who provide similar services. Yes, I mean, definitely routine practices applies to all healthcare settings. So most definitely does apply throughout. Next slide.
I think this is supposed to be me on this one. So what are things to be aware of when treating patients, and how do I protect myself, staff, and other patients? And we hope that this webinar has already provided you with some key resources to address this question, where you can look to get ideas. And obviously, routine practices is your go-to for this. Next, please. And this is supposed to be me and Isabel on this one. So is physiotherapy clinic considered a healthcare setting? Well, we believe it is. You're a regulated healthcare provider, and this is a communal setting. And even if people are asymptomatic, we say everybody has germs. So do a risk assessment. Anything else you'd like to add on that, Isabel?
No, madam, that's it. I mean, you are a regulatory college, and so you do fall under the healthcare setting format.
Thank you. Next question. So this one I would have a go at. Best practices for screening patients for acute infectious diseases, and which ones involve mandatory reporting. So you can look in clinical office practice and the routine practice and additional precautions Annex B, particularly for acute respiratory infections. And there's an actual chart on Appendix A. But the bottom line is, if someone comes in, your signage should say, do you have a new or worse cough, shortness of breath, or fever, that kind of thing. And that flags to you that they probably have a potentially contagious acute respiratory illness. And then you might also want to ask about travel history too. Consider also diarrhea and vomiting symptoms. Can their appointment be moved to when they're not symptomatic? And this is something Louise referred to before, and that you're pre-screening, so they wouldn't be coming into the clinic if they had symptoms, if at all possible. However, sometimes this isn't possible. Some of you work in acute settings, and you have to provide care to people who have respiratory infections and so on. From the point of mandatory reporting, used to be reportable diseases, and now it's called diseases of public health significance. And you can find that, we have a link here, but it's on ontario.ca laws regulation. And this is a relatively new wording, diseases of public health significance, but your public health unit will have this in a chart form. So you can just Google it and you will find one, or you can just contact your health unit and say, please, can you provide this for me? And you can print it up and have it in your office so you can see what is reportable and what's not. Next, please.
So this one is for the college. Can physiotherapists tell patients that they would like them to change their clothes or wash their hands or do other things like that before coming to physiotherapy? And yes, you can. So if someone comes smelling strongly of cigarettes, as in the example, you can ask them to wash their hands and change their clothes. Same thing if you had a scent-free policy, you could ask them to wash off the scent.
Great, thanks. And maybe this one, Isabel, would you like to do?
Sure. I'll take this one. So this one's got multiple things going on here. So again, physiotherapists, you are not seeing the same level of patients. You're not providing the same level of care as a physician would, or your clientele typically doesn't come in with an upper respiratory infection, or they're having a gastrointestinal issue. So again, consider all those points. But if you think about it, best practices for infection prevention and control apply in whatever setting you're in. So it's pretty much consistent from one setting to another, whether you are in a clinic, in a hospital, or providing care at home in somebody's home. If you consider hand hygiene, you still need to do good hand hygiene before and after you've provided care or the service that you are there for. Risk assessment. Always consider the risk assessment. What are the risks? What are you walking into? Does a person have an infectious illness? So you need to be aware of what's happening with your patient/client. You need to consider the environmental controls. So where are you? Where are you providing the care? Are there issues with cleanliness? You never know what you're going to walk into when you walk into somebody's home if you're providing care in the home. So always sort of have that in mind, whatever setting you're in. Administrative controls, whatever's available to you there, Anyway, so there's a lot of things to consider as you go in. And of course, your personal protective equipment. Do you have those on hand? So you need to make sure that you have everything with you. In a hospital, it's easy. Everything's there. When you're providing care in the home, you need to take it with you. You need to be sure to have what you need to provide the service that you're there to provide, taking into account what's happening with your client as well. So sort of consider all those pieces. Anything else to add, Madeline?
Yeah, I was just going to say that IPAC Canada does have some useful resources. We have position statements and practice recommendations, and you can just Google IPAC Canada and you can put position statement if you like, and it'll take you to them. There's one about non-critical devices and equipment in community settings, and that gives you some good advice about, surface cleaning and things of what you're taking in and taking out of people's homes in a home care setting. And we're going to be working, I chair the Standards and Guidelines Committee at the moment, and we're working on also some things, similar things for semi-critical and critical devices. So that'll be coming soon too. But I think you'll find some useful resources there, and it is available to everyone. You don't have to be a member to get that information. Next, please. Okay, so the next one sort of continues on that really about what resources would be considered when writing a comprehensive IPAC policy for a physio clinic, and how does this differ from a home care company that doesn't have an actual physical clinic. So I think some of this has already been addressed. We would say look at the PIDAC documents, especially the one about clinical office practice. It gives you a lot of great guidance there. Again, for the home setting, look at that IPAC Canada practice recommendations that we mentioned. And we like to say don't be the traveling germ. So, you know, people in their home settings, it's mostly their own germs. So they're less at risk of somebody else's because it's their own space. But if you yourself are going person to person, you potentially could be transmitting those germs or bringing those with you. So it's really important that you don't become that traveling germ. Next, please. Okay, and I thought this one would be good for Louise.
So again, when we're conducting the investigation, we are looking at who the investigation is to. So if you are a health, oh my goodness, I'm having a provider, we are looking at your practices, and we're looking at the facilities that you are using within your practice. Provision for sanitizing of tables. Again, you're following routine practices within your practice. So when we're investigating everything that you are doing, not anything that you're renting or anything like that. So it is actually specific to your practice.
Thanks, Louise. I was going to also add to this that don't forget you're a regulated health professional, so you are responsible for your own best practices. And if your opinion is not the same as the chiropractor who owns your clinic, then it's your responsibility to meet with the owner and share evidence to support your recommendations. Thanks. Next, please.
I think this question is the same as well.
Yeah.
So we're looking at where you are practicing and providing care to your clients. So if it's a space that you are renting or a space that you are using, then we are looking at all the different parts of the treatment rooms, the reprocessing room that you are using, and we're looking at that. So we're not looking at if you're renting a space, we're not looking at other spaces that other professionals are using. We are actually just looking at your practice.
And this is for Louise as well.
So again, it depends on the definition of what a spa is. If it's a medi-spa by a healthcare practitioner, and then we are investigating the healthcare practitioners. But if it's we call them personal service settings. So if it's a spa where there's nails and hair being done, then we, at the health unit, there's actually a personal service facility regulation, and we have our own checklists as well that we are using when we are investigating, and we actually routinely inspect personal service settings. So if you are renting a space within a spa, again, if you are the person that the investigation is, we are only looking at your spaces in your areas. But if you're sharing space, then we will investigate those spaces that are being shared. And then two, we provide recommendations to yourself and to the other facility or the spa that's providing you that space, because they are using that space as well. And we want to make sure that the IPAC practices are being done within both the healthcare facility and the non-health regulated facilities as well.
And we recommend too about things being able to be cleaned. So the question about vinyl versus cloth, we recommend that the surfaces can be cleaned and disinfected, and it's rather hard to do that with cloth. So
That's right, and especially in spas, they have that atmosphere, and now that we have a regulation for personal service settings, we can then now actually, for those facilities, you can write orders and tickets to get those into compliance. It's a bit different now.
Thanks, Louise. And this one, hand hygiene. There are so many hand gels, foams available. Are there any that are better than others, and why? Is there any truth to the rumor that hand sanitizer is toxic? Well, we recommend, PIDAC recommends 70 to 90% alcohol-based hand rub, and if it's not alcohol-based, there's not sufficient scientific evidence to support its use. So we really say look for that in a healthcare setting. It's very beneficial if you have your staff involved in the choice. So maybe have a little pilot of a couple of products at least to see which appeal to the staff, because it's very important to have compliance. So if they buy into it, they're more likely to use it. Now, from the toxicity point of view, well, it's generally not. It's not toxic to have it on your hands. The alcohol is not absorbed into your skin or anything, into your body. There could be some, detrimental effects if it's ingested. So you need to check the manufacturer's instructions for use. I know that one product has a bit of Bitrex in to make people, feel sickly if they put that in, stuff to stop people biting their nails. So I know some people will do anything to get alcohol, but look at the products and see which one best meets your needs, but make sure it's 70 to 90% alcohol for your setting. Next, please.
Did you want me to take that one, Madeline?
Yes, if you wouldn't mind. And then Sherry, there's a thing about there for the college, but I think Sherry's in agreement with us, so please.
So, so cleaning, what products to use to clean plinths? So essentially, and I just saw a question that just got posted, if Cavicide can be used. So ultimately, you need to clean and disinfect your surface or your plinth. So just always remember that it needs to be cleaned and disinfected. There are products like Cavicide that are 2-in-1. So it's doing the cleaning and the disinfection all in one. So yes, that is appropriate. We certainly can't recommend one product over another. That's not our role. But as long as you're using the appropriate product, that's fine. And that it has a DIN. Again, remember you are part of a healthcare setting, so you need to keep that in mind. And when you are using these cleaner disinfectant solutions, make sure that you're aware of the contact time. It has to stay on the surface for a certain amount of time. So it all depends on the product you're using. It could be from 2 minutes, 3 minutes, up to 5 minutes. It all depends on what you're using. So always be aware of the product that you're using and the manufacturer's instructions for use. And I see we're probably running out of time. And Sherry, I don't know if you wanted to maybe forward to us the list of questions that have come in. We can certainly answer and provide.
We have till 15:15. We have till 1:15, yes. So we'll just be concise in our responses, and we should be all right.
Yes, good, perfect.
One, Isabel, was about the table, and you and I had discussed this, and you either wipe the table down between uses and when soiled, so you have to look, and at the end of the day, if a paper cover is used. So look at the clinical office practice best practices, and that will give you suggestions for that. Okay, next, please. And this is a question about belts and braces that people might lend. So rather than give you a yes or no question on this, we would say, what are they made of? Can they be laundered? If they're plastic, can they be low-level disinfected? And, they can be reprocessed. But if you can't wash them or clean them adequately, perhaps you might want to consider not sharing them. But see what happens. Now, I understand some of these belts are not even put on people. They are maybe used for physiotherapy, so that with around equipment to pull on and things like that. So look at the uses, look at if it's cleanable, disinfectable, follow the manufacturer's instructions for use too. So what instructions do they give for cleaning and reprocessing these items? But generally speaking, if it's been used by others, it should be cleaning and low-level disinfection or laundering. The next one is about a baby chair, which is a lovely idea, but yes, of course, it's an infection risk. And if it's cloth, you could cover it with a disposable sheet or a cloth sheet. That would be a good idea, preferable if it was plastic, a plastic cover, so that you could clean it and wipe it off after each use with a low-level disinfectant. Okay, next one, please. Okay, this one too, I'll take this one quickly. Best method to clean stethoscopes with respiratory infection so it doesn't damage your stethoscope, and the dedicated equipment may be poor quality in a hospital setting, and it's fine to have your own stethoscope, but you should be cleaning and disinfecting it, preferably with something like a wipe with appropriate contact time, and not just when somebody's got a respiratory infection, but between every patient or client. Next, please. So, Sherry, this is, does the college recommend anything? Because we don't.
No.
Not allowed to, right?
No, we wouldn't. And I think that Louisa answered the question about the Cavicide in particular. Look at what meets your needs and choose the product that's right for you.
Exactly. And make sure it's friendly to the surfaces that you need to clean. That's, acceptable to the manufacturer, and also to your staff. If it's very toxic, awful smell, they're not going to use it. So what we'd point out here is that it's not a sterilization agent. The difference between sterilization and disinfection is that disinfection kills all the vegetative forms and sterilization kills spores.
Oh, and also to look at your efficacy claims on your disinfectants. If you're cleaning up a blood spill, then you're looking for efficacy claims on bloodborne infections. So you're looking at what you want to kill on that surface, and then make sure the product has a kill claim on that.
Right, good.
Can I just pop in for a quick sec?
Yes, please.
So we've been using Cavicide 1 since the inspection. And it does really leave a residual smell in the office because they're closed doors all the time. And so there is a question, of course, of toxicity to both the staff and the patient with regards to that. Any comment on whether there's a product that doesn't have that same sort of residual, hyper sort of clean? It smells like I can gag actually on it.
Well, it's Madeline here. I'd suggest that maybe look for another product that might not smell that way. It's not toxic. I mean, it's not, but people have sensitivities, and if people don't like it, they're not going to use it. And this often happens with, products that have bleach in them. Bleach is a great disinfector, not so good a cleaner, but of course, and it's also sporicidal in certain concentrations, but there's the smell issue. So you need to look for another product that, the smell, and somebody made a suggestion there of Oxivir TB wipe. So have a look around, but look at the contact time too. If you can get a short contact time, it's more likely to be effective, because the thing has to be kept wet. If it says 5 minutes, it might be hard with a wipe to keep a surface wet for 5 minutes. So bear all those things in mind.
Thank you.
The next one here is for Isabel.
Yeah, so the question was related to soap and water plus 70% alcohol. Is that sufficient to clean vacuum sponges between patients? Some electrotherapeutic equipment does use sponges to transfer current. The only thing we can say is follow the manufacturer's instructions for use as far as the cleaning, the reprocessing of them. I'm not sure what the requirements are, but definitely do follow that. That's what we're going to call them NIFUs. That's what they're there for. So refer to that. And as far as alcohol, the alcohol typically requires 10-minute contact time for low-level disinfection. So hopefully that answers that second part of the question.
Great, thanks. And then, can we use fabric pillowcases? Well, yes, you can use them, but if they're going under a patient's or client's head, then you probably should be changing them between clients. If they're going between knees and the clients have their clothes on, less of an issue with transfer of organisms, but they should be laundered between client use. Next, please. We put this next one to Louise because there are requirements for cleaning, and you can find that in the Pilot Best documents too. But if you wouldn't mind, Louise, commenting on what temperatures and things like that, like
probably using the Public Health Ontario's resources for cleaning and disinfection of environmental surfaces. That's probably the best document to use for this because I'm unaware. I think warm water would be effective. But again, I think that document would be the best resource for that.
Yeah, and it does have guidance for so much temperature and time for cleaning, for laundry, and in a healthcare setting and so on, and drying as well. Thanks. Okay, the next one is about magazines, and there's no truth to the rumor that magazines are a high risk. There is no evidence, published evidence to support this. And think about libraries, and they probably will be closed down, wouldn't they, if everybody's getting germs off the books. However, there are sicker people going into libraries, into healthcare offices and libraries, perhaps. So the best thing is to encourage people to clean their hands before and after use of the magazines, and turn them over, throw them away, recycle them fairly frequently. Okay, next one. Maybe I can do this quickly then. What's the protocol for infection control records in hospital? Are the charts considered an infection control issue, and is there alternative? So we weren't sure what you meant by this, the person asking this, but we were thinking that you were talking probably about the same thing, the charts in both cases, and your hospital should have a process that aligns with accreditation standards if it's in a hospital setting. Patient records can be a vector for infection transmission, so generally the charts are not kept in patients' rooms, and healthcare workers should clean their hands before touching them and probably afterwards too. If a patient's on contact precautions and the chart is traveling with the patient, some facilities put the chart in a plastic bag, but there's really no evidence, as we mentioned before, that paper is a great transmitter of germs. And so have a look at how it's used in your setting. Next, please. Okay, home care. I wanted to touch on that. We thought you ought to really have a PPE kit with you for, so you have your gloves, your facial protection, your clothing protection, alcohol-based hand rubs, some disinfectant wipes, do personal risk assessments, and, refer also to the IPAC Canada document about home care settings. Next one, if Isabel, you could address the acupuncture.
Sure. The question here asked about the sharps container, should it be kept in a locked box? So we weren't too sure if you meant literally the sharps container, which is already a locked container, if you meant that should then be in a separate locked box as well. So we weren't too sure what was meant by that. But again, a sharps container should be easily accessible to you if you're using sharps. And we're just kind of wondering why this question is asked. So is the container not an approved type of sharps container? Or you just basically, is it a jar, you're opening the lid, putting them in, which I don't believe that's the case, but we're just kind of wondering about that. Or perhaps your clientele, would they be high risk for looking for used needles? We weren't too sure what that meant here. And as far as...
Can I comment on that? Because I think it came up certainly on our audit. And Louise, if you want to just comment, because what you had sort of mentioned was that the sharps container does need to be securely locked to the wall, so it's not accessible to anybody kind of reaching for the sharps container, or in a locked cupboard when you're not in the room. I think that's where the question's coming from.
And then in storage as well, the Ministry of Labor requires that all your sharps containers are stored away and locked, so that when they're coming to do their investigations, your sharps containers aren't just out in public areas.
Oh, well, I thought they have to be at point of use. So
yes, well, that's what I mean. They should be at point of use and locked, but also, again, if you're putting them into a storage room,
while waiting to be disposed of. Yes.
Exactly.
Yes.
That's what I meant.
Okay, so yeah, if we're talking about a full container waiting to be disposed of, yeah, that's a completely different story. Of course, they need to be in a area where there's no access. Your clientele do not have access to them, for sure.
So can we just clarify so that everyone's really clear? What you're saying is that the container itself is locked by nature of how it's made, but that it also needs to be, as Louise showed in her PowerPoint slide, locked to the wall as you would see in a physician's office per se. That's not typical for physiotherapy clinics. I think that's what needs clarification.
It's also not typical or not required in a dental setting, for example. They have to have it in a secure place, not out in a public area, but they can have it on a counter if it's not about to tip over. So they don't have to have it locked to the wall. So I think it is a bit more setting specific, but basically there's nothing in any of our PIDAC documents that say it must be locked to a wall. So I think you have to look at where you've got it. If it's in a setting where there's people going by and they could just pick it up and take it out and do off with your used sharps, obviously that's not a good idea. But if it's in a treatment area and it's securely in there, then it doesn't have to be locked to the wall. So I think it's worth maybe exploring that a bit more in a bit more detail, in our responses afterwards. I'm sorry, my battery is somehow failing here. My cord is not charging it, but we wanted to touch on the gloves because I also discussed that with Sherry. And when you're doing acupuncture, needling, and so on, you need to consider what's your risk of getting blood on your hands. And probably very, very low, since you're not going in areas where there would be bleeding. Your hands are not close to the insertion site and you're holding the needle far up. If you're treating someone and you're new to this and you also, the person has a bleeding disorder, maybe you want to put gloves on for that. So you do a risk assessment. And the answer for the best by date, look at your manufacturer's instructions for use on that. Isabel, I'm sorry, you're off camera. If you could move over a wee bit. Somebody wants to see your face. Thank you.
Oh, okay.
Okay.
So I'm conscious of the time, and we've gotten through so many questions. I didn't think we would get through this many, and so I'm actually kind of thrilled. But I think we do have to cut it short today. I want to thank all the panelists for giving up of their time and their expertise today. We really appreciate it. The session will be archived on the college website for those who came late or left early or were kind of overwhelmed by all the information like I was. It'll be there for people to access. And I also want to say thanks to everybody who submitted questions either during the session or beforehand. We will compile a list of questions that were not addressed during the session and post somewhere on the college website, whether that's through the newsletter or attached as a frequently asked questions with the standard. I don't know what that's going to look like yet. And you may not see your exact question. We will sort of repackage the ones that came in that are similar in order to provide a succinct but comprehensive resource. So I will ask the panelists whether they had any final words. No, they're shaking their heads. I can see them, but maybe you can't. And again, I thank everybody for your time.